Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Ali Ahmed Muhammad al-Sharif, 6th-year medical student. Today I will present this presentation which is talking about bronchial asthma as brief. This is our objective. First of all, we will start with definition. After that, we will go to pathophysiology of this bronchial asthma, then diagnosis, and last and not least, management. What is asthma? Asthma is defined as a chronic inflammation disease of airway that is characterized by increased responsiveness of tracheobronchial tree to a multiplicity of stimuli. There is a risk factor or host like extrinsic, which is episodic, and atopy, intrinsic, perennial status asthmatox. Pathophysiology of asthma. There is triggers will induce the vasoconstriction of or bronchoconstriction of the bronchi. These triggers may be allergen, virus, cold, irritant, exercise, and so on. This will lead to hyperreactive response, bronchospasm, then edema, then airway obstruction. This is a bronchial asthma under a microscopic. You can see there is a vasoconstriction or bronchoconstriction in the left side, which is not normal with bronchi. Now we will talk about asthma diagnosis triad. As any disease, you should start with history. History of the asthma, it is intermittent shortness of breath, cough, chest pain, wheezing, and this all come from triggers and may associated with disease like allergic rhinitis, atopic dermatitis, food allergy. Normally you found family history, genes for asthma, allergy, physical, and you can diagnose by physical exam, what is all the time or not all the time, maybe it's normal, and you can confirm diagnosis by spirometry, or it is facability or probability if it is coming with wheeze. As we said, it's by history and examination. Variable respiratory symptoms that suggest asthma, as we mentioned before. After that, history and physical examination. Then it is, if it's yes, there is you are suspicion of the asthma, you must do spirometry, which is forced respiratory volume, before and 10 to 15 minutes after bronchodilator. Relief airway limitation, if it's relief, if it's more than 12% from baseline, this is asthma. Then we will go to a stepwise approach for age of 12. This is for management or treatment. As you see, there is 4 cycle or 4 parts of types. First of all, intermittent asthma, which is mild. This we can treat it by short-acting beta agonist as needed, of course. If it is presented asthma, daily medication, you need low dose of inhaled corticosteroid, thiobilin, cromelon, and maybe consider subcutaneous allergen immunotherapy for patients who have persistent allergic asthma. If preferred treatment, you may, if it's third or fourth step, you may need medium dose of inhaled corticosteroid with long-acting beta agonist. If it is more severe, you may need high dose of inhaled corticosteroid with LABA and considered omizumab for patients who have allergy. If it is very, very severe, you need to do high dose of inhaled corticosteroid with LABA, with oral corticosteroid, and consider omizumab for patients who have allergy. Finally, asthma complication. It may be pneumothorax, which is the first complication you suspect if there is severe asthma, pneumothorax, pneumomediastinum, pneumopericardium, pulmonary interstitial emphysema, cardiac arrhythmia, myocardial asthma, or myocardial ischemia or infarction, mucus plugging, atelectasis, pneumonia, electrolyte disturbance, hypokalemia, hypomagnesemia, hypophosphatemia, lactic acidosis, hyperglycemia, and therapeutic toxicity. Thank you for listening and hope we will get well. Assalamu alaikum wa rahmatullahi wa barakatuh.